switch from COVID to monkeypox. The next speaker will be Assistant Professor Opass Putcharoen. He's staff at the Faculty of Medicine, Department of Medicine, Faculty of Medicine at Chulalongkorn University. He is currently head of the Thai Red Cross Emerging Infectious Diseases Clinical Center, as well as he's the acting deputy director of the Thai Red Cross AIDS Research Center. Dr. Opass will talk about Mpox and HIV, please.
Thank you very much for invitation. First of all, thanks the organizer for invitation to give a talk today on HIV and Mpox and HIV. This presentation will be more likely a clinical presentation, so it will be very easy for clinicians and nurses who want to know about Mpox and HIV. This is my disclosure. So this is the outline of the topic that I'm going to cover today. I'm going to talk about the situation of Mpox situation globally, and also include the situation in Asian countries and in Thailand, what's going on here. And then touch a little bit on the virus, about the genetic of virus, that we have the chance to look at the genetic properties of the virus that infect our patients. And tomorrow you are invited to attend the workshop that I will explore a lot more on the intracellular, intrahost evolution of the Mpox in HIV patients, and the role of alphabet 3Gs on its addition on Mpox genome of the virus in HIV infected patients. So tomorrow I will present those data. And I will also include the clinical manifestation, treatment, prevention in my talk, and issue in people living with HIV. So let's talk about the situation first. This is the epi curve since mid-2022 until now. You can see that now the new cases per week of Mpox is lower than the early epidemic in 2022, but we can see you can see that we could see the background of low-level transmission, and we could see some multiple surge in the cases from time to time. This is the global situation now. What is the cause of the multiple surge since August 2023? When we look at the data from European countries here and the data of new cases per week in Asia, you could see that some of the cases contribute to the global level of surging came from the Asian countries. When we look specifically at among the Asian countries, I include Thailand, Japan, the Philippines, and Singapore. You can see that the trends of increasing the number of cases per week in many Asian countries. When we look at Thailand, comparing to the early epidemic in 2 years ago, we start seeing the surge of the cases since the mid of last year. And as of January 6, 2024, we have a total of 690 cases of Mpox cases in Thailand, and we have 4 deaths among these populations. So I literally believe that the case that we are now seeing is the tip of the iceberg. We have many undiagnosed cases because of my illness, and some of them may not seek for treatment and diagnosis. So we are seeing the tip of the iceberg now. For the Mpox, this infection is the endemic disease in South Africa, in Africa for such a period of time. There are 2 clades of Mpox in Africa. The first clade is South African clade, or clade 1, which contribute to 10% of mortality rate. And the other clade is West African clade, which is a problem now because now we have the problem with this strain, this clade or clade 2. The clade 2 virus has spread from Africa to the other part of the world. The mortality rate of West African clade is less than 1%. It's very low, but it has increased the property of human to human transmission. And for the reproductive number of the clade 2 virus, it is 2.2, meaning that one patient can contribute to 2 or 3 infections to the other people. This is the genetic analysis of the individual who present to Thai Red Cross AIDS Research Center for Mpox infections, and all of these confirmed by PCR, and we have the chance to look at the genetics pattern of the Mpox virus in patient in our center. This includes a total of 53 patients or 53 individuals. Since the 2022, we noticed that we have imported case from many countries, and we could see the clade that were prevalent at that period was 2BA. And now we see a lot of clade 2BC in our patients since mid-2023. So from this genetic analysis, it's telling us that in the past, we have the imported case of Mpox from the other countries. Now, when we look at the genetic characterization of the virus, we could see the local transmission among Thai population already. So we are now having the problem with clade 2BC viruses. It has been believed that the virus has its adaptation for fitting with the transmission in human. In the past, clade 1 and clade 2B virus has well adapted in its transmission from animal to the human. Now, we have the problem with 2BB1 and 2B, the other 2B viruses that has its adaptation to have ability to sustain human-to-human transmission. And from the animal models, has been shown that the virus that we are having now, although it have high level of human-to-human transmission, the virulence in animal model is very low. So this is the virus that will adapt for its transmission, but has lower virulence than their counterparts. Let's move to the clinical manifestation. When I look at the textbook that we used in the past about Mpox or monkeypox, the clinical manifestation of Mpox during outbreak is different from the thing that's described in the textbook. There are so many symptoms that different from the description on the Mendel's textbook. In this situation, in this outbreak, the most of the cases are male patients, and most of them are men who have sex with men. 60 to 70% of the people who have Mpox in this outbreak has no fever, no systemic symptom. Only 1% of them has symptoms associated with upper respiratory tract infections. For the rash, 80 to 90% of them have rash, and the characteristic of the rash is ulcerations or umbilicated lesions. 7% of them has vesicles. 1% presented with pustule or papules. And the most important thing is the rash distribution is more likely at the urogenital lesions, at the genitalia and anal areas, half of them. And approximately 17% of them have the rash in the oral mucosa. So which is very, very useful information for making the diagnosis of Mpox in high-risk individual, because many of them presented with rash in anogenital areas and oral mucosa. There has been some report of asymptomatic infections of Mpox in some countries. they found that the Mpox can be detected in rectal tissue or rectal swab in individuals who present to the clinic with asymptomatic STI screening. So this is the asymptomatic infection that may occur in Mpox infections. And some of the literature describe pre-symptomatic transmission 3 to 4 days before symptom. So asymptomatic infection and pre-symptomatic transmission contribute to difficulty in the management of spreading of Mpox. So this is an example of the rash. It may be extensive rash, or some of the patient may have very minimal rash that may be difficult to be detected by physical examinations. So on the upper left is the rash in a patient who admit to the hospital with diffuse rash, and at the first time the diagnosis syphilis was diagnosed, but the serology for syphilis did not confirm the diagnosis. So the physician sent PCR from the lesion for Mpox, and then it turned out to be positive. So on the right lower pictures are the patients who presented with rash, and they provide the risk of sexual contact with some suspected Mpox individual. So the rash is very minimal, and you need to look for the rash at the oral genital area to make the diagnosis. So these are the clinical manifestation of rash. Sometimes it's very difficult to make the diagnosis. For example, this gentleman, he presented to ARV clinic for receiving antiretroviral treatment, and the physician noticed that he has rash at near the lips, and asked about the history of the rash and the history of sexual contact, and then the physician suspect that the patient might have Mpox, so we did the swab from the lesion and sent for PCR, and PCR came back confirmed that this patient have Mpox. Some patients may have oral lesion like this, and some of them may have genital lesion that look like syphilis or herpes simplex infections. Some of them may present it with dysuria and swollen of the prepuce. So these are the unusual manifestation of Mpox infections. So what about co-infection? This is the cohort that enrolled about 2,000 individuals with confirmed Mpox diagnosis in the US. The study showed that patients with Mpox have very high prevalence of STI. Most of them report the prior diagnosis of STI during the preceding years. For example, 1/3 of them reported they had gonorrhea in the past. 1/4 of them reported having chlamydia, and 15% of them have co-infection with syphilis. So screening STI is very important in Mpox patients. This analysis also look at the difference between Mpox in HIV and without HIV infections. You can see from the slide that Mpox in HIV infection, they usually have higher proportion with STI and higher chance to be hospitalized because of the severe disease. And many of them already receive antiretroviral therapy. And the other interesting issue from this analysis is when they look at the people who have Mpox without HIV infections, approximately 70% of them are PrEP user. So this information is very important to apply the education and STI screening, Mpox screening in PrEP user, because you know that the STI is very prevalent in PrEP user. So screening and testing Mpox should be incorporated into the routine care for people who coming to the clinic for receiving the PrEP. when we specific look at the symptom, this is the same analysis. They look at the symptom of Mpox in patient with and without HIV. You can see that in people living with HIV, they have higher proportion to have the symptom. For example, rash, fever, chills, and malaise. And the proportion of anogenital symptom is prevalent in people with HIV as well. Many of them reported that they have rectal pain, tinnitus, rectal bleeding, or proctitis. So anogenital symptom is prevalent in people living with HIV comparing to those without HIV. Mpox in HIV patient with low CD4 is a nightmare for both clinician and for the patients. So this is a picture from the Lancet that describes the clinical feature of Mpox infection in people living with HIV, and many of them have low CD4. You can see that the lesions tend to be more severe and large, and some of them may be confluent, and some of them have necrotizing lesions. And also, in HIV patients with low CD4, they are likely to have internal organ involvement from Mpox. Some of them may have nodules from Mpox, and some of them might have gastrointestinal involvement and may cause gastrointestinal perforation and has complication and die. This is an example of one patient in our center. This gentleman is a 40 years old man. He used to take HIV medicine, and then he continued his medicine for 3 years due to non-adherence. And he presented to the clinic with a rash on his face, anogenital area. He presented to our clinic 6 months ago. At that time, we cannot get access to TRCARC easily, so we need to wait for approval to get the antiviral for him. So this is the progression in the hospital. After 3 days, you can see the lesion become enlarged, and he become sicker, and many lesions become confluent. And 1 week later, we could get the approval for treatment for him. We gave him TRCARC. This is the example of rapid progression of Mpox in people living with HIV. For the diagnosis is very easy. You can send a PCR from the lesion for confirm the diagnosis. However, this is in the WHO guideline. I mentioned that some patients with Mpox may not have visible skin lesion, so detection of Mpox can be made by alternative specimen, for example, from the oral or rectal swab. It may be useful for making diagnosis in cases without visible skin lesion. This is our analysis on the right-hand side. Infographic show that the data from our own patients, we could find the virus in the skin, at the oral mucosa, and in the rectal swab, urine and blood as well. And many of them still have a high concentration of the virus in oral mucosa and rectal mucosa, despite there is no visible lesion in the oral or rectum. Let's move on to the treatments. Right now, there is no approved treatment for Mpox. The drug that we are now using is the drug for treatment of smallpox. This is the same virus in the same family. We have the drugs for the treatment of smallpox, but this medicine has not approved for the treatment of monkeypox or Mpox. There's a trial that now ongoing to see the efficacy of the medicine for treatment of Mpox. TRCARC is widely used but has not approved yet for treatment of Mpox. TRCARC is a drug that uses its mechanism that it can inhibit the protein VP37 and inhibit the formation of the envelope of the virus. This action can be applied in Mpox virus as well. So now we are using this for Mpox infection, but under the emergency protocol. FDA has not approved yet. The other drug that's available but not approved as well are cidofovir and brincidofovir. These two agents inhibit DNA polymerase of the virus in vitro and has been used in animal models for treatment of pox virus. So these two may be applied in some difficult cases. This is a recommendation from the US CDC about the treatment of Mpox infection by giving the antiviral TRCARC or TPOXX. It's recommended that antiviral TRCARC should be given in patients with Mpox diagnosis, but only in severe cases, such as patients with hemorrhagic disease, large number of lesions, septic patients, or patients with disseminated viral infection from Mpox like encephalitis. And the other indication for giving TPOXX is involvement of some important anatomical area, which may result in serious sequelae. For example, at the eyes, at the urethral orifice, or some patients who have the lesion at the perineal area that may interfere bowel movements. So these are two indications for giving TPOXX for Mpox treatments. You should remember that most of the cases are self-limited. Only some cases need antiviral. And in this guideline also mentioned about early treatment in patients who have risk to have severe disease. For example, immunocompromised patients presenting with minimal lesion, but they tend to have severe disease. For example, people living with HIV without treatment for HIV, those with CD4 T cells, low CD4 T cells, patients with leukemia, lymphoma, or malignancy, or solid organ transplantation. These individuals need treatment at the need early treatment. And also pregnant women, pediatric population are also included in indication for high-risk population for having severe disease. So this population needs to receive TPOXX or TRCARC. This is the recommendation for the dose and the route of administration of the TPOXX medicine. TRCARC is there are two forms of TRCARC, oral form and IV form. Adjunctive therapy such as cidofovir or brincidofovir can be added after no response to the treatment. There's a recommendation from CDC guideline about Mpox in people living with HIV. It suggests that TRCARC should be administered at the early course of the illness in patients with advanced HIV. And for ART recommendations, if patient has not started ART should start on the same day or immediately after Mpox diagnosis. Because when we want to treat infection, for example, Mpox in people with immunosuppressive status, we need to give antiviral, and together with boosting immunity, in this case, we need to give immediate antiretroviral therapy. And also, you should expect to see iris in this case as well. Treatment failure may be occur in patients who receive TRCARC because of its property. The drug has very low genetic barrier for for the treatment, and resistant testing may be considered in the patient who still develop disease after 1 or 2 weeks of TRCARC administrations. And if you think that the patient have treatment failure, you need to send the virus for genetic characterizations to see whether the virus has some mutation that confer resistance to TRCARC. And the cutoff time is 14 days after the treatment. If you still see new lesions or progression of lesions, resistant testing need to be considered. I have 3 minutes for the prevention. There are so many interventions that can be applied for Mpox control. But all of these things need to be used in combination. Not one intervention cannot achieve the Mpox control. For example, during the early stage of the Mpox outbreak, there was no vaccine. The best thing to control the infection is to adjustment of risk behavior. For example, try to reduce the number of sex partners, try avoidance of sexual engagement, or avoid high-risk sexual activity. However, adjustment of risk behavior alone cannot control the Mpox situation because this is human. Some high-risk sexual activity may be resumed after a while. So this is a simulation of the effect of adjustment of risk behavior and the transmission of Mpox. Risk behavior alone can reduce the number for a while, and then the new infection come back again later. So on this right-hand graph show the importance of we should use the other intervention in combination to suppress the new case. In this simulation, they look at the adjustment of risk behavior alone in the dashed line, and when we apply vaccine in high-risk population. So you can see that with vaccine, we can suppress the new case into the low level. So it should be used together. For the vaccine, now we have 2 types of vaccine available. One is DO1, CAM2000, which is replication competent virus. And the other one is MVA or Jenios that used in the US. This vaccine is non-replicating virus. It is safer for MVA comparing to Dryvax. And the efficacy of this vaccine has been shown in many trials for prevention of Mpox. The vaccine for Mpox can be used as pre-exposure prophylaxis before exposure, and then for post-exposure prophylaxis as well after 14 days of the exposure. So you can use either pre-exposure prophylaxis or post-exposure prophylaxis. And the route of administration, you can use subcutaneous or intradermal route for administrations. And the volume of subcutaneous route is 0.5 ml, and the volume of intradermal route is less 0.1 ml. It is 1/5 of the subcutaneous dosing. So it's more economical for using the intradermal route. For the vaccine effectiveness, this is the analysis in high-risk populations, and the analysis has been shown that the vaccine effectiveness was 60% in people who received 2 doses of Jenios for pre-exposure prophylaxis. And for the post-exposure prophylaxis, the vaccine effectiveness was approximately 80 to 90% for prevention of infection after the exposure of the Mpox virus. This is the dosing schedule. You need to get 2 doses of Mpox vaccine, 28 days apart, and vaccine can be used in kids less than 18 years, And for the Genios, it is safe in immunocompetent and immunocompromised patients and can be used in pregnant women as well. This is a recommendation for people who are eligible for the vaccine. Not all people are eligible for Mpox vaccines. Mpox vaccine should be considered in healthcare workers who work in the lab or who have the risk to expose to the patients, and high risk population for STI. This is an indication. So vaccine is not for all people. Need to be given to the high risk population and healthcare worker to have the risk to expose to the Mpox virus. But the problem is vaccine equity. This is the same challenge in COVID-19 vaccine that we have the problem in resource limited setting. The vaccine is not well distributed, and we need to look for the strategies that can give the vaccine to high-risk population in poor countries or in countries that have the problem with Mpox, such as in Asian countries now. I think this is my last slide, what we have to do for the Mpox outbreak. This is the example from our center. We are now using multiple strategies to control Mpox in Thailand, in Bangkok. We have the funding from NIH to support the antiviral agents, TRCARC, under the access by storm trial that are now ongoing. So we're now recruiting the individual with Mpox infection and those with risk to develop severe disease can get this medicine for free under the access of under the research project. And at the end of this month or at the beginning of next month, Thai Red Cross are now launching the vaccine program for high-risk population. So this is the strategy that the Thai Red Cross trying to tackle Mpox situation in Bangkok and in Thailand by importing the vaccine and can provide the vaccine for high-risk individual. So I think I would like to end here, and this is my team that did the analysis of the virus, Mpox virus, from our patients. Thank you very much.